mine that I've had the pleasure of working with, and she is doing research on modulators and nutrition. So I will let her start sharing her screen, and I will turn it over to Dr. Juliana Bailey. Thank you so much for being here.
Thank you for having me, Georgia. I'm honored to be here with everybody today. So I am Dr. Bailey. Like Georgia said, I'm a registered dietitian and I have been in clinical practice for 12 years. I just recently earned my doctorate from the University of Alabama at Birmingham, and my focus is on cystic fibrosis, nutrition, and health behavior research. So currently I spend a good chunk of my time doing research in CF, but I also do still see patients in clinic as the University of Alabama at Birmingham adult CF program dietitian, which is my dream job, to have a mix of both patient care and getting to do research on this topic that I'm so passionate about. So thank you again for having me today. I'm going to speak on modulators and nutrition, and I'll share with you some of the data from my dissertation study where I examined the nutrition and metabolic outcomes associated with Trikafta, but I'm going to refer to Trikafta by its trade name or abbreviated by ETI throughout the presentation. So I'll start off by giving some background. I think everyone here is familiar with what cystic fibrosis is. It is a genetic disease that's autosomal recessive, and it affects the CFTR protein. This causes electrolyte transport across the epithelial cells that is dysfunctional. There are over 2,000 different mutations of CFTR that have been identified. And as we all know, CF primarily affects the lungs, but also the GI system. And up to 90% of patients have exocrine pancreatic insufficiency. And nutrition has long been defined by body mass index, or BMI. And this is because BMI is closely associated with lung function and therefore survival in CF. So although CF has a wide variety of intestinal manifestations that lead to malnutrition, there's also a high risk for micronutrient deficiency and essential fatty acid deficiencies. Eating disturbances and body image issues are also common because we focus so much on weight and weight gain from a very early age. Every 3 months, somebody's talking to you about your weight or talking to your parents about your weight, and really focusing on getting in tons of calories, at least historically. And we actually have really limited evidence for what the optimal diet is in CF. And like I mentioned, nutrition outcomes, particularly BMI, have long been a key measure of health in people with CF for the Cystic Fibrosis Foundation. This is really because optimizing BMI was linked to improved pulmonary outcomes. And I think a lot of you have probably seen these graphs here. On the left, we have children. On the right, we have adults. And here in the y-axis, we have lung function represented by FEV1. And down here, we have BMI percentile for children, and then just raw BMI number for adults. And you can see that on both graphs, for both men and women who are represented by red and blue lines, that as BMI increases, so does lung function. So there's very close association between these two metrics. And for this reason, the Cystic Fibrosis Foundation set goals of having a BMI that was on the higher side of normal, 50% or higher for children, or 22 for women and 23 for men with CF. So to give the historical perspective on nutrition and CF, malnutrition was most commonly the feature associated with this disease. That's also associated with lower lung function and poorer survival. And BMI has long been the main marker for nutrition status, although this is slowly changing, and we're starting to look more at other measures like body composition and laboratory values, which I'm very happy about. And there was sort of what we call the legacy diet for CF, which was the high calorie, high fat, high salt, and high protein diet. Always just pushing calories to help get the BMI up to optimize outcomes. So some of the causes of malnutrition include increased work of breathing, malabsorption, having chronic inflammation, and increased calories burned at rest for all of these reasons. However, as most of us know, the landscape of nutrition and CF is really changing. Everything is improving with these new drug developments and advances in clinical care. So with this, malnutrition is becoming less and less common, and overweight and obesity are actually increasing. So I pulled some of these graphs from the CF Foundation Patient Registry Report, and that report lags behind a little bit because the registry has to clean and annualize all the data before they release it. So we only have up until 2020. But you can see here that for children 2 to 19 years, we have BMI in the red. It's been steadily increasing over the past 20 years. And we have this graph of BMI for adult men and women over here too. And again, the same trend. It's steadily increasing over the past 20 years. And you can see this really sharp uptick here at 2019 to 2020. We saw an even bigger increase. And there was a paper that came out recently that analyzed the whole CF Patient Foundation registry over the past 15 years. And they found that the percentage of obesity had increased by 300% in this population. So things are definitely changing. And although we do still have malnutrition in the CF, we now see the entire spectrum of nutrition status, from malnutrition all the way up to obesity, and then everything in between. There is really no more one size fits all dietary recommendation for people with CF. So now I'll shift gears just a little bit and talk about CFTR modulators. These are the first drugs to treat CF at the cellular level. They are genetic mutation specific, and they have been found to improve lung function, quality of life, and in some cases, nutrition parameters. So I have broken out a brief review here of CFTR modulators and their effect on nutrition status. So for ivacaftor, which was the first modulator that was approved, there was significant weight gain in children and adults who had one copy of the G551D mutation. There was also improved linear growth in children, meaning they actually had catch-up height growth on this drug, which is really incredible. And the effect of BMI, or the effect on BMI, was actually not significant in adults who had different mutations such as R117H, or children who have the most common pair of mutations, and that's 2 copies of delta F508. So for ivacaftor, lumacaftor, the effects on BMI were really mixed in adults with class 2 mutations, and there was no significant change in BMI in children who had 2 copies of delta F508 who were taking ivacaftor and tezacaftor. So for nutrition and ivacaftor, there's the most evidence on this drug because it's been around the longest. So we've had the most time to study it. And Dr. Jennifer Gimbalot from University of Alabama at Birmingham studied the long-term effects of ivacaftor. And she had some findings that showed that both overweight and obesity increased in adults and children with long-term ivacaftor treatment. So you can see in this graph over here, we have pediatric and adult groups. The first bar is the baseline measurements, and you can see that the majority of participants at baseline, 85%, were in the normal BMI category, 9% were overweight, only 2% were obese. But after 5.5 years on the drug, the proportion of overweight increased significantly from 9% to 18%. We saw a similar trend in adults, with the proportion of overweight increasing from 16% to 25%, and obesity increasing from 8% to 11% after 5.5 years on ivacaftor. And then we saw here in adults too that the rate of malnutrition or underweight declined. So just to give a little summary of anthropometric measures such as weight, height, and BMI and modulators, in all participants with gating mutations such as G551D who took ivacaftor, they had significant weight gain. Results were mixed with respect to weight gain on the combination drug ivacaftor and lumacaftor in adults with class 2 mutations. And these are class 2 mutations include delta F508, which, as we all know, is the most common CF mutation. Adults who had 2 copies of delta F508 did have significant increases in BMI on ivacaftor paired with lumacaftor. And children with 2 copies of delta F508 did not have any change in BMI on the same drug. So sort of a difference between adults and children's on the same drug. And there's currently no evidence available on the role of diet or how CFTR modulators impact body composition. So we do have very limited data on body composition and ivacaftor from a couple of studies that I wanted to present. So Edgeworth and colleagues found no change in fat-free mass, and fat-free mass is lean body mass combined with bone. They use something called bioelectrical impedance analysis to measure body composition. This is an instrument that just sends a really light current through your body to measure the resistance to body water and can tell you how much fat-free mass and fat mass you have. So in short term on ivacaftor, of just 28 days, there was no change in fat-free mass. Virginia Stallings and her group reported an increase in both fat mass and fat-free mass using DEXA scans after 3 months on ivacaftor. So DEXA scans are really the gold standard for measuring body composition. They give really detailed data about muscle mass, fat mass, and bone mineral density. And then I just wanted to point out that bioelectrical impedance analysis, or BIA, may over or underestimate fat mass and fat-free mass in people with CF. So like I mentioned, that's why we really love the DEXA scans. They are the gold standard. They're just really hard to get in clinical practice. So what about Trikafta, or the mouthful elexacaftor, tezacaftor, ivacaftor, or ETA? As we all know, up to 90% of people with CF are eligible to take this drug. You only need 1 copy of delta F508 to be eligible to take it. So they found in clinical trials that there was a significant improvement in not only lung function, but also sweat chloride levels and quality of life. There was also an improvement in BMI of about 1 kilogram per meter squared. So this is considered a highly effective modulator, similar to ivacaftor. So I wanted to talk just a little bit about the potential mechanisms of weight gain on ivacaftor. And we have some limited data there, but Virginia Stallings and her group examined people with CF who had gating mutations, that G551D, that also took ivacaftor. They found that resting energy expenditure decreased by 5.5%. Resting energy expenditure is how many calories somebody burns at rest. It's how much energy your body needs to just take care of all of its normal functions while you're at rest. This doesn't include the amount of calories you burn from exercise or your daily activities. But still, this was a big finding because how many calories people were burning at rest decreased significantly after they started taking ivacaftor. They also found improved absorption, both through fecal elastase, excuse me, for pancreatic sufficient patients. They also did 72-hour fecal fat studies and found that fat absorption was increased by that metric as well. They also found decreased gut inflammation. And when they did body composition measurements, they found increased fat-free mass. And they also found that participants had increases in hand grip strength after they had been taking this drug for 3 months. And this is just a graph that shows the relationship between resting energy expenditure and fat-free mass. So the same group also examined dietary intake changes with taking ivacaftor. And they had a group of North American people with CF, and they also had a group of Italian adults with CF who were part of this study. And you can see here the estimated energy requirement. This is the percentage of estimated energy requirement that patients were consuming. This is calories per day, essentially. So you can see that the Italians significantly increased their estimated energy intake. They were consuming more calories, whereas North American participants' calorie intake pretty much stayed stable. There was no significant change there. And then when we come and look at dietary fat, both the Italians and the North Americans significantly increased their fat intake after 3 months of taking ivacaftor. And so they hypothesized that maybe this increase in fat intake was due to the fact that the drug comes with instructions that say take with a fat-containing food twice a day. They didn't ask patients why they were increasing their fat intake, but this was sort of a conclusion that they came up with as a possibility for why this was the case. So now that we've got some background on modulators and the limited evidence and how they affect nutrition status and dietary intake, I wanted to talk a little bit about my dissertation study, and I'll go over the aims, sort of the methods, and then I'll give you guys the results. So our first aim was to describe changes in nutrition and metabolic parameters in a subset of adults with CF who were prescribed Trikafta in the clinical setting. And we also wanted to explore to see if there were any associations between nutrition and metabolic changes and CF clinical outcomes, including lung function and BMI. So we hypothesized first that BMI was going to improve with Trikafta treatment. We also felt that resting energy expenditure would decrease. Again, that's the number of calories that you're burning when you're completely at rest. And we hypothesized that calorie intake would increase on the drug and that people's upper body muscle strength would also improve after taking Trikafta. So we had a lot of different outcome measures, but first and foremost, we wanted to take weight and height so we could calculate BMI. We also measured resting energy expenditure through a technique called indirect calorimetry, which I'll talk just a little bit more about in a moment. We also measured dietary intake through 3-day diet records, and we did hand grip strength measurements. And we also kept track of how many pancreatic enzymes patients were taking along with their 3-day diet records. So indirect calorimetry is a really cool procedure. It tells us how many calories somebody's burning at rest, and it's actually using a PFT machine. So you can see my lovely test patient who let me perform this test on them while I was learning how to do the procedure, posed for this picture. Participants lie at rest for 30 minutes, and then we put this clear plastic bubble over their head and shoulders and sort of tuck that plastic in all around. And then this blue tube that you see is going from that bubble over here to a PFT machine. And the patients just lie there for 30 minutes at rest and breathe normally. And the machine is able to give us estimates of the amount of energy produced by biological oxidation. So in order to do this test, participants had to be fasting for 10 hours prior, and that's pretty standard. The hardest part of the test, I'd say, was, not falling asleep, because we usually do it first thing in the morning. And people can't have access to anything that might increase their respiration by making them laugh or, so people can't watch music, they can't play on their phones. So the hardest part, I think, is just sitting there with nothing to do for an hour and not falling asleep. So hand grip strength. I wanted to show you guys a picture of the hand grip strength tester in case you've never done it in clinic or as part of a study. It's a really simple procedure where you just hold this piece of equipment and you squeeze it as hard as you can for 3 seconds and then let go. And it takes a measurement of the force of your grip strength. So we all know BMI has typically been used to determine nutrition status in CF, but lean body mass or muscle is more strongly associated with lung function. So hand grip strength doesn't measure someone's muscle mass or their body composition, but it does give us information about their upper body muscle function. And some clinicians and researchers feel that it can be reflective of lean mass body stores, even though it's not a direct measurement. So this study was an open label prospective observational cohort study of people with CF who were clinically prescribed Trikafta. It was a sub-study to the larger PROMISE study, which you may have heard of. And the PROMISE study was looking at sweat chloride, lung function, weight and BMI, and quality of life, and how those things changed over 2 years of participants taking Trikafta. So for the study design, we obtained informed consent prior to the baseline visit. We took baseline measurements up to 30 days prior to the patient's first dose of Trikafta. And then our second visit occurred at 28 days after the first dose. And our third visit, sort of our long-term follow-up visit, occurred at, or it was supposed to occur at 6 months after the first dose, but the COVID pandemic was going on sort of between visit 2 and visit 3. So visit 3 got a little delayed. So we recruited from the UAB Adult CF Clinic and Children's of Alabama Pediatric CF Clinic. We could recruit age 16 and up. We ended up getting 22 participants at baseline. 4 of them, or 18%, were pediatric. And then we had 17 participants complete all 3 visits. So just briefly, with the analysis plan, we used NDSR software to analyze diet records. This is a research grade nutrition analysis software. We calculated descriptive statistics on all of our variables of interest, both for our whole sample. And we also broke things out between patients who were heterozygous and homozygous for Delta F508. We calculated changes in outcomes at both time points using paired t-test. And we also ran a repeated measures ANOVA. And we used Pearson and Spearman correlation coefficients to look for changes in outcomes at each time point, or associations between changes in our outcome variables. So the fun part, the results. What did we find? So just some demographic data at baseline, 95% of our participants were white. This is typical of, this was reflective of our CF population locally in our adult and pediatric programs. 50% were homozygous for Delta F508. The mean age was 26 years, but as you can see, we had a range from 16 up to age 54, and 68% participants at baseline were female. So some more baseline characteristics. The mean BMI was 22.8. We did have a range in BMI of 17.2 to 31.1, which again, this is pretty indicative of what we see these days in CF. We have a range of BMI from malnutrition up to obesity and everything in between. The mean resting energy expenditure, which is expressed as percent of predicted, was 113% of predicted. So that means that participants were burning higher calories than we would expect using our standard calculations for them. So this is also typical in CF and has been observed frequently in the literature. The mean calorie intake at baseline was close to 3,000 calories a day, and the mean fat intake was up to 127 grams per day. So patients were consuming about 40% of calories from fat, and this is at the top of what is recommended currently for people with CF. The recommended range is 30 to 40% of calories from fat. So our patients were eating a high calorie, high fat diet on average. And then I also broke out the BMI status so you guys could see this. At baseline, we had 36% that had optimal BMI according to the CF Foundation, and anyone under that was considered underweight. That was 41% of our patients. 18% were overweight and 5% were obese at baseline. So we found that BMI increased with Trikafta therapy. This was also seen in other retrospective studies that have come out since Trikafta has been on the market. The mean difference in BMI was 0.46 kilograms per meter squared at between visit 1 and 2, so 28 days, and between baseline and I've listed everything as 10 months for visit 3. That was the average amount of time to visit 3, even though we had initially written for things to be collected at 6 months, the pandemic delayed us, so we ended up getting that between 10 months and a year. But between baseline and our third visit, BMI increased 0.92 kilograms per meter square. So this is just slightly lower than what was seen in clinical trials as far as increase in BMI on the drug. However, that is probably to be expected because this wasn't a clinical trial. This was an observational study sort of looking at how patients did on this drug in a real world clinical setting. So our proportion of overweight increased over the course of this study and underweight decreased with long-term therapy on Trikafta. So we increased to having 29% of our patients classified as overweight. And our one patient who was in the obese category when we started the study actually ended up coming down into the overweight category. That's why you see that change. We did have pretty small numbers for this study, but I did still think it was interesting that the proportion of overweight increased because this was also what was seen with Dr. Gimbalat's long-term study of ivacaftor. We also found that calorie expenditure decreased with chronic use of Trikafta. So at baseline, people were what we call hypercatabolic. They were burning more calories at rest than we would expect. And you can see that that decreased significantly by 6.6% over the course of the study. So people's metabolism slowed a little bit with Trikafta use. Pancreatic enzyme dosage was unchanged throughout the study. We calculated this both in dosage of units of lipase per kilogram per meal and units of lipase per kilogram per day. Both measures were unchanged and not statistically significant over the course of the study. You can see here, we did have one participant who is this dot down here that was on an extremely low dose of enzymes at baseline and quit taking them altogether on Trikafta. There was also no significant change in hand grip strength over the course of the study. Hand grip strength remained stable. This is different than what was observed with ivacaftor. And we're not entirely sure why this is, but we've wondered if people's physical activity levels were also impacted by the pandemic, which was happening at the same time, because for a while we had a lot of social distancing and people were isolated in their homes, not going to the gym, not going out to exercise as much. So total calorie intake also increased with long-term use of ETI. From baseline to 10 months on the drug, people increased their calories by an average of about 300 calories per day. And total fat intake also increased with long-term use of Trikafta between baseline and our 10-month long-term follow-up time point. Participants on average increased their fat intake by 19 grams per day. And again, this may be because people are instructed to take the drug twice a day with a fat-containing food. So protein and carbohydrate intake remains stable from baseline to short-term and long-term follow-up. There were no significant changes with either of these macronutrients. And macronutrient balance also remained unchanged with use of Trikafta. This means the percentage of calories coming from carb, fat, and protein. This makes sense because we saw that only fat intake increased, and that's probably what was driving the increase in total calories that we observed. We also measured the glycemic index, which is a measure of how quickly carbohydrate will cause your blood sugar to increase based on food type, and glycemic index remained stable throughout the study. We also wanted to look at fat-soluble vitamin intake because we know that people with CF are at risk for developing these deficiencies, and fat-soluble vitamin intake remained constant. There were no significant changes in vitamin A, E, D, and K intake, either from food or from supplement over the course of the study. We also examined the healthy eating index, and this is a validated measure of diet quality that's based on the dietary guidelines for Americans. It is ranked on a scale of 1 to 100, with 100 being the best possible score. And just to give some perspective, the mean healthy eating index for US adults is 59. So 59 out of 100 is it's not great. It indicates fairly poor American diet quality based on the dietary guidelines. And the median healthy eating index in adults with CF is just a little bit lower than the general population. at 48.3. And this number down here in CF comes from previous work by Dr. Bellissimo and Dr. Jessica Alvarez at Emory University. So because we have these detailed diet records, we also wanted to see how the healthy eating index in our sample compared to the Emory sample and to the US national average. So we found that the baseline healthy eating index here was around 50 at baseline, and it almost didn't change at all between baseline and our 10-month long-term follow-up. This was not statistically significant. So diet quality was essentially poor at baseline and did not change throughout the course of the study. So just to give a little bit more information about this healthy eating index, it's made up of 9 different components. There are 4 components, which are refined grain, added sugar, saturated fat, and sodium intake that are considered, these are the domains you want to score low in. And then the rest of the domains, such as unsaturated fat, fruits and green vegetables, low-fat dairy, lean meats, those were domains you wanted to score higher in. And I pulled out a few that I thought were relevant to CF. So refined grain intake in our sample was higher than the US national average at each point. However, refined grain intake did decrease significantly at long-term follow-up in our study. Added sugar intake was comparable to the US national average at each time point, and this also decreased significantly. Saturated fat intake was higher than national average at baseline. Our participants' saturated fat intake also increased over the course of the study duration, and unsaturated fat intake was lower than the national average. And when we're talking about unsaturated and saturated fats, saturated fat comes from animals, and it's typically considered the type of fat that is associated with developing cardiovascular disease. So unsaturated fats are heart healthier fats. They typically come from plant sources. So in conclusion, we found that Trikafta increased weight and BMI status rapidly at 28 days. The result was sustained with chronic treatment at longer than 6 months. Our participants increased their calorie intake, and this increase paired with the reduction of the calories they burn at rest are mechanisms of weight gain on this therapy. So the universal high calorie, high fat diet recommendation in CF probably needs to be revised given rising BMI in this population. So our study had some limitations. We did have a very small sample size, and we were also unable to thoroughly assess body composition. However, there was an endocrine sub-study to the PROMISE study that did look at body composition in a couple of sites, and those data should be out sometime soon. We did have attrition or loss of participants related to the COVID-19 pandemic. And this is observational data, so it comes with all of the limitations of an observational data set. We are not able to establish causation. So for future directions, we plan to look at longitudinal trends in larger sample sizes, and we also want to expand this work into the pediatric population. With this, we'll add measures of body composition, absorption, and serum biomarkers for nutrition, metabolomics, and inflammatory markers. And we also want to do an additional exploration of healthy eating index components that are driving poor diet quality in this population. And questions remain. We still need to know, is overnutrition in CF causally linked to metabolic and clinical outcomes? We know it is in the general population, but this has just not been studied well in CF, so there's a lot of unknown there. We also still don't know what the optimal diet is for people with CF, but I think if there's one thing that we can take away from this work and ongoing work is that there is no one size fits all diet for CF. That was prescribed for a long time, but I think now in clinical practice, the approach has to be very individualized and tailored to each patient and their needs. So we also need to know how can we help people with CF meet their personal nutrition goals when taking modulators. We don't really know the best behavioral strategies. There's just not been research on that. And we also need to know how modulators affect endocrine outcomes in CF, such as CF-related diabetes, because as we all know, CF diabetes has an impact on people's diet and their personal health goals as well. So I've got my references listed here. And then I also wanted to give some acknowledgements, particularly to the participants who completed my study. Without them, none of this work would have been possible. I have my dissertation committee listed here, Dr. Stephen Rowe and the Gregory Fleming James Cystic Fibrosis Research Center, and Dr. Barbara Gower in the Nutrition Obesity Research Center, and our funding source here. So now I will do my best to answer people's questions and hear your comments.